Okay, in this video we will talk about the mood affective disorders. This chapter discusses the disorders associated with presenting complaints in chapter 6, 10, and 11, which you might find helpful to read first. In chapter 6, we've talked about suicide and self-harm. In chapter 10, it was about depressive disorders. Chapter 11 was about bipolar affective disorder. And chapter 10 and 11 was about cyclothymia and dysthymia. Okay, so let's start with depressive disorders. Epidemiology. Here we have a table that summarizes the epidemiology of the mood disorders. Epidemiology of the mood disorders. Okay, here it is. We have the lifetime risk, the average age of onset, and the sex ratio, female to male. About recurrent depressive disorder, it's about 10% to 25% for women and 5% to 12% for men. This is the lifetime risk. The average age of onset is late 20s. Sex ratio, female to male, is 2 to 1. Bipolar affective disorder, the lifetime risk is 1%, the average age of onset is 20 years, and the sex ratio is equal. Cyclothymia is about 0.5 to 1%. The onset of age is adolescence and early adulthood. It has equal incidence for males and females. Dysthymia is about 3 to 6%. The onset is in childhood, adolescence, and early adulthood. Female to male ratio is 2 to 3 to 1. Okay. So, what about etiology? Depression is a multifactorial disorder with interacting risk factors from many aspects of a patient's makeup. Genetics, early upbringing, and personality can increase vulnerability to depression, with episodes arising depending on the level of acute and chronic stress experienced. Okay, here we have this figure that can demonstrate things. Okay. Okay, so we have genes, genetic predisposition, we have early life experiences. So this is the simplified model of etiology of mood disorders. Genes with early life experiences, in addition to stress, all of these things can, affect each other to lead to the mood disorder. And actually, mood disorder itself can lead to stress and vice versa. So that's it. Let's talk about these factors one by one. Genetics. Twin studies show the heritability of depression as 40 to 50%. The genetic risk is likely to be contributed by multiple genes of individual small effect. So we have 40 to 60. Okay. The heritability. Okay. Interestingly, recent genome-wide association studies have found that genetic variants that increase the risk for depression also increase the risk for other major mental disorders. The particular genes involved are only beginning to be identified, but so far include genes involved in calcium signaling, mitochondrial enzymes, and regulation of growth of new neurons. To complicate matters further, some genetic influence may only manifest in particular circumstances, gene-environment interaction. What about early life experience? Parental separation, divorce during childhood increase the risk for depression in adult life. This may partly relate to the loss of a parent and partly to the disruption of care to the child. Other types of childhood adversity, for example neglect, physical and sexual abuse, increase the risk for depression and other psychiatric disorders. Postnatal depression in mothers can be associated with an indifferent early upbringing, leading to poor self-esteem and increased risk for depression in the child. So, parental separation, neglect, physical and sexual abuse. Okay, what about personality? Genetics and early upbringing combine to shape personality. So it is unsurprising that some personality features are associated with increased risk for mood disorders. The personality trait neuroticism, which means anxious, moody, shy, easily stressed, has consistently been found to increase the risk for unipolar depression. Certain personality disorders like borderline personality disorder and obsessive compulsive personality disorder also increase the risk for depression. What about acute stress? Acute stress. Adverse life events are common around the start of a depressive episode, particularly loss or humiliation events such as bereavement, relationship breakup, or redundancy. The life event may not necessarily be causal, as being depressed or at risk for depression may also increase the risk for experiencing adverse life events. In recurrent depression, later episodes are less likely to be triggered by life events. What about chronic stress? The psychological and physiological effects of chronic stress may make someone vulnerable to depression and also reduce their ability to cope with more acute stressful life events. Chronic stressors such as poor social support, like lack of someone to confide in, not having employment outside the home, and raising young children are associated with depression. Chronic pain and any other chronic illness, particularly heart disease and stroke, are associated with depression. So here we have some, chronic causes. Poor social support, not having employment, raising young children, all of these things, and chronic pain and, of course, and chronic illnesses. So what about neurobiology? The final common pathway of the multiple etiological routes to mood disorder is abnormal brain structure and function. It is likely that mood disorders are due to malfunctioning communication between multiple brain regions involved in emotion regulation, rather than just one key abnormal area. Recurrent early onset depression is associated with reduced volume of the hippocampus, amygdala, and some regions of frontal cortex. Hippocampus, amygdala, and some regions of the frontal cortex. Depression with onset in later life is associated with white matter hyperintensities on neuroimaging, thought to be to represent small silent infarctions. We are talking about, of course, recurrent early onset depression, while in later depression is something else. Neurochemically, multiple interacting neurotransmitter pathways are likely to be important. The two main abnormalities identified in depression are overactivity of the hypothalamic pituitary adrenal axis and deficiency of monoamines, noradrenaline, norepinephrine, serotonin, and dopamine. So, okay. We've talked about assessment, clinical features, and investigations, and differential diagnosis in chapters 6, 10, and 11. You can get back to that if you want more. What about management? A biopsychosocial approach is considered for the management of depression, which means that consideration should be given to treating biological, psychological, and social aspects of the illness. Let's talk about treatment setting. Most patients with depression can be treated successfully in primary care or in a psychiatric outpatient clinic. Day hospital attendance may be helpful in patients with chronic or recurrent illness, especially if poor motivation or low self-esteem has led to a reluctance to go outside the home and make contact with others. Intensive support at home from crisis teams or inpatient admission may be advisable for assessment of patients with highly distressing hallucinations, delusions, or other psychotic phenomena, active suicidal ideation or planning, especially if suicide has previously been attempted or many risk factors for suicide are present, and if there is lack of motivation leading to extreme self-neglect like dehydration and starvation. So you need to admit the patient if there is psychotic symptoms, active suicidality and high risk for suicidality, and lack of motivation that lead to self-neglect. Detention under mental health legislation may be necessary for patients who need admission but are unwilling to accept inpatient treatment and lack capacity to make decisions regarding their treatment. Lifestyle advice. All patients with low mood should be advised to avoid alcohol and substance use, eat a healthy diet, exercise regularly, and practice good sleep hygiene. Avoid caffeine and smoking in the evenings, do not sleep during the day, set regular sleep and wake times, do not use bedroom for other things like studying, watching TV. Patients can be referred to exercise groups. Discounts may be available for those suffering from depression. So here you have this. Okay. Avoid alcohol use, substance use, eat healthy diet, exercise regularly, practice good sleep hygiene. Okay. Okay, what about psychological treatments? The National Institute for Health and Care Excellence, NICE Guidelines 2009, recommends that psychological treatments are used first line for mild depression. So that's it. And in combination with drug treatments for moderate, severe depression. The severity of depression is determined in part by the number of symptoms, but mainly by the degree of functional impairment, whether the patient is still able to fulfill their normal social and occupational roles. We've talked in chapter 3 that chapter that covers psychological treatments in detail. Modalities often used in depression are CBT, cognitive behavioral therapy, interpersonal therapy, psychodynamic therapy, family therapy, and marital interventions, mindfulness-based cognitive therapy. Communication. Patients reluctant to take medication may prefer the idea of talking therapies. It is worth noting that cognitive behavioral therapy can be as effective as antidepressants in treating moderate depressive episodes, and that when used after medication, it can reduce the rate of relapse up to 4 years later. You may want to discuss both options with the patient, encouraging the use of both, but allowing the patient to make the final decision. This often aids concordance. About pharmacological treatment, NICE Guidelines NICE 2009 recommends antidepressants only for patients with moderate to severe depression, or for patients with persistent subthreshold depressive symptoms or mild to moderate depression who have not benefited from low-intensity psychosocial interventions. And of course, SSRIs are recommended by NICE Guidelines as first-line antidepressants because they have the fewest side effects. SSRIs like sertraline, paroxetine, citalopram, fluoxetine, and so on. All antidepressants are similarly effective if prescribed at the correct dose and taken for an adequate length of time. Clinicians therefore tend to choose an antidepressant based on not on efficacy but on its side effect profile, taking into account patient preference and comorbidities, and on which symptoms of depression are most troublesome. Here we have a table that summarizes some of the factors guiding the choice of an antidepressant. So here we are talking about factors influencing choice of antidepressant. About side effects. SSRI in general are the best tolerated antidepressants for side effects. Side effects should be matched to a patient's symptoms, lifestyle, and preferences. For example, the weight gain caused by mirtazapine may be preferable to the sexual dysfunction caused by the SSRIs. Some patients benefit from the sedation caused by some antidepressants like tricyclics like amitriptyline or trazodone or even mirtazapine. Another factor that influences choice of antidepressants is previous good response. So, the consideration is to the prescription of a previous drug. Another factor is risk for overdose. SSRI are safer in overdose than venlafaxine, which is safer, of course, than tricyclics. Severity of depression is another thing. For severe depression requiring hospitalization, antidepressants that affect both noradrenaline and serotonin may be preferable. That is, tricyclics and high dose of venlafaxine, SNRI. So that's it, serotonin and norepinephrine. SSRIs may be slightly less effective in treating depression of severity sufficient to cause hospitalization. Atypical depression. And this is another factor. Atypical depression, like that has these symptoms of hypersomnia, overeating, and anxiety, may respond preferably to MAO inhibitors actually. Comorbid physical health problems. This is another factor to take in mind. SSRIs can cause or worsen hyponatremia. SSRIs should not normally be prescribed to people taking an non-steroidal anti-inflammatory drug, warfarin or heparin, as SSRIs increase risk for bleeding. SSRIs should be avoided in those taking triptan drugs for migraine. Tricyclics are contraindicated in patients with a recent myocardial infarction or arrhythmias. Okay. Comorbid mental health problems are also considered. Patients with obsessions or compulsions may respond preferably to high-dose SSRI or clomipramine, something that works on serotonin. A depressive episode with psychotic features usually requires an adjunctive use of antipsychotic medication. You consider that. Okay. We've talked about a lot of these drugs in chapter 2, so you can see that for more information on antidepressant mechanism of action and side effects. Antidepressants are most effective in moderate to severe depression, where around 50% of patients will respond, compared with 30% on placebo, when prescribed at an adequate dose for a sufficiently long period, usually 4 to 6 weeks, longer in older adults, with appropriate patient education and encouragement, of course. When an antidepressant has brought remission of symptoms, it should be continued at full dose, at the dose that induced the remission, for at least 6 months to reduce the relapse rate. So, okay. Patients with a history of recurrent depressive disorder may benefit from taking antidepressants for a longer period, perhaps even lifelong in severe cases. The prophylactic effect of antidepressants in reducing relapse has been demonstrated for at least 5 years with imipramine. Treatment often fails due to inadequate dose of drug, duration of treatment, or poor concordance. Therefore, these factors should always be ruled out. In this book, this book describes the strategies that can be used when a patient has not responded to an antidepressant at the correct dose for the correct length of time. So, when an antidepressant does not work, management options include: confirm concordance first, confirm duration of treatment and dose, at least 4 weeks at minimum therapeutic dose. Longer periods may be required in older adults, of course. Reassess the diagnosis. Is depression the cause of their low mood? Are they using alcohol or substance? Do they have a different psychiatric disorder? Is there an ongoing psychosocial stressors? And so on. Then consider psychological therapy, if this is not already in place. Increase the dose of the current antidepressant, increasing for example, increasing fluoxetine from 20 to 40 mg. You can change to another selective serotonin reuptake inhibitor, like from fluoxetine to sertraline. And if trialed two SSRIs or not appropriate to do so, we change to another antidepressant from different class, from SSRI to SNRI, like venlafaxine or mirtazapine. If adequately trialed at least two antidepressants, consider augmenting the current antidepressant with lithium or another antidepressant, for example, mirtazapine, usually done by psychiatrist. This is an example. So, after the trial of two antidepressants, you consider the augmentation. Okay. Antipsychotics can also be used as augmenting agents in treatment-resistant depression. There are many other options. Consider electroconvulsive therapy if criteria met. Okay, here we have common pitfalls. Patients may tell you that they have already taken antidepressants and that they do not work. People often respond to antidepressants from some classes but not others, so it can still be worth trialing a different antidepressant. You may want to explain this before prescribing. Remember that patients are often prescribed inadequate doses for inadequate lengths of time before the medication is changed. This does not represent treatment failure, for which a treatment dose need to have been prescribed for 6 to 8 weeks without a response. You may find it useful to document dose and treatment period in your drug history. Okay, to consider that the drug has been tried appropriately, it needs to be at least for 4 weeks, and we need 6 to 8 weeks optimally. Okay, what about electroconvulsive therapy? In chapter 2, we've talked about that, so you need to check that for more information on the administration and the side effects of ECT. But here we will talk about indications for ECT in depression that include poor response to adequate trials of antidepressants, intolerance of antidepressants due to side effects, depression with severe suicidal ideation, depression with psychotic features, severe psychomotor retardation or Sqour, depression with severe self-neglect like poor fluid intake or food intake, and previous response to ECT. What about the course and prognosis of depression? Depression is self-limiting, and without treatment, a first depressive episode will generally remit within 6 months to 1 year. However, the course of depression is often chronic and relapsing, and around 80% of patients have a further depressive episode, with the risk for future episodes increasing with each relapse. Depression is one of the most important risk factors for suicide. Rates of suicide are over 20 times greater in patients with depression compared with those in the general population. Okay. Now we will talk about bipolar affective disorder. We've talked about the epidemiology of that, so let's go to the etiology. Similar to depression, bipolar disorder is thought to arise from an interaction between genes and environmental stress, with genes being particularly important. Twin studies estimate heritability at 65 to 80%. First-degree relatives of a patient with bipolar disorder have a roughly 7-fold increased risk for bipolar disorder, 10%, a 2-fold to 3-fold increased risk for unipolar depression, 20% to 30%, and a high risk for schizophrenia, schizoaffective disorder. Okay. Thus, genetic susceptibility for the severe mental disorder is not disorder-specific. Patients with a family history of any bipolar, schizophrenia, or schizoaffective disorder are at increased risk for bipolar disorder. Risk for most patients is likely contribute to the multiple alleles of small individual effect, although some rare high penetrance allele probably also exist. Many of the mutations identified so far that slightly increase the risk for bipolar disorder also increase the risk for schizophrenia, including genes related to neuronal development, neurotransmitter metabolism like dopamine and serotonin, and ion channels. The most important environmental risk factors is childbirth. There is a 50% risk for mania postpartum in those with untreated bipolar affective disorder. Okay. Neurobiologically, structural and functional abnormalities in brain regions linked to emotion and reward, particularly hippocampus, amygdala, anterior cingulate, and corpus callosum, have been identified. Multiple neurotransmitter pathways have been implicated, with strongest evidence for dopaminergic pathway hyperactivity in mania and some evidence of dopaminergic hypoactivity in depression. We've talked about assessment, clinical features, investigations, and differential diagnosis in chapters 10 and 11. What about management? The main management scenarios are treatment of acute mania or hypomania, treatment of acute depression, and the maintenance treatment, which means prevention of relapse. Treatment setting. The initial treatment setting depends on the presentation and severity of illness. A manic episode needs referral to secondary care. It may be managed by a crisis team, but may necessitate a period of hospitalization in cases of impaired judgment enduring the patient or others around them, like sexual indiscretion, overspending, or aggression, or even with significant psychotic symptoms, or even excessive psychomotor agitation with risk for self-injury, dehydration, or exhaustion, and of course thoughts of harming self or others. Detention under mental health legislation is often necessary in those lacking capacity to make decisions regarding treatment. Patients with bipolar disorder may also require hospital admission for depressive episodes for reasons outlined in the section on depression above. Let's start talking about pharmacological treatment. The mainstays of acute and maintenance treatment of bipolar illness are mood stabilizers, lithium, and some antiepileptics like sodium valproate or valproic acid, lamotrigine, and carbamazepine. And of course, antipsychotics, which stabilize mood as well as reduce psychotic symptoms. About the treatment of acute mania or hypomania or mixed affective state. Antidepressants should be discontinued. This may need to be gradual if half-life is short to avoid discontinuation symptoms. So this is first. Short-term benzodiazepines are often helpful in reducing severe behavioral disturbance. An antimanic agent should be started. NICE 2014 recommends an antipsychotic like haloperidol, olanzapine, quetiapine, or risperidone, in part because of their benefits in reducing behavioral disturbance. If a different mood stabilizer is already being taken, it can be continued with consideration given to increase the dose. If there is no improvement, augmentation is recommended with an antipsychotic. So, okay. Because lithium can be harmful if taken for less than 2 years, discontinuation of lithium can precipitate mania. It is not advisable to start lithium in a manic patient who is unlikely to be concordant with long-term treatment. Okay. Treatment of acute depression in context of bipolar disorder. Antidepressants need to be co-prescribed with an anti-manic agent to avoid precipitating a hypomanic or manic episode. They should not be prescribed for mild depressive symptoms, only moderate to severe. Doses should start low and increase only gradually. Often, choice will be influenced by what medication someone is already taking. The first line options are either quetiapine or a combination of fluoxetine and olanzapine. Okay. Quetiapine and olanzapine have antidepressant properties in addition to antipsychotic effects. So we have this, the combination of either quetiapine or a combination of fluoxetine and olanzapine. Antidepressant properties in addition to antipsychotic effects. Okay. If these medications are not of benefit, lamotrigine alone can be given. If someone is already taking lithium or valproate, ensure the dose is providing a level at the upper end of the therapeutic window, is at maximum, and consider augmenting in turn with the 3 options as above. Long-term antidepressants should be avoided, with gradual discontinuation once depression has been in remission for 3 to 6 months. Okay. About maintenance treatment. Not everyone who has suffered from a manic or hypomanic episodes needs long-term prophylactic treatment. Maintenance treatment is recommended in those who have had a manic episode associated with serious adverse risk or consequences. A manic episode and another disordered mood episode, or repeated hypomanic or depressive episodes with significant functional impairment or risk. Treatment for at least 2 years is recommended, but in practice is often required lifelong. If maintenance treatment is indicated, NICE 2014 recommends lithium as first line. Lithium requires regular blood tests, usually 3 monthly, to monitor plasma level for lithium itself. Discontinuation of lithium can precipitate relapse, meaning net benefit is likely to be gained only after at least 2 years of treatment. Second line is to augment lithium with valproate. If someone is not able to take lithium, cannot tolerate, cannot attend to routine blood monitoring, alternatives are valproate, not in a woman of childbearing age, of course, as it is associated with a high risk for neural tube defects. But we have these options: valproate, olanzapine, or quetiapine. Third line options are lamotrigine, protects poorly against the manic pole, or carbamazepine, high risk for drug interaction due to induce of liver enzymes. But here we have these options. Hints and tips. Do not forget to take a comprehensive family history, including of treatment of psychiatric diagnoses. There is evidence to suggest that the level of response to lithium runs in families. Red flag. Different preparations of lithium and valproate, which can mean sodium valproate, valproic acid, or semisodium valproate, have different bioavailabilities, so it's important to specify the preparation when prescribing. Okay, about physical health monitoring. People with bipolar affective disorder are at increased risk for cardiovascular disease, regardless of whether they are taking medication with metabolic side effects or not. NICE 2014 recommends an annual physical health check, including weight, pulse, fasting blood glucose, glycosylated hemoglobin, lipids, and liver function. Any abnormalities should be protectively treated. Extra monitoring is required for those taking lithium. We need renal function, thyroid function, and calcium. Psychological treatment. A structured psychological intervention is recommended for all people with bipolar affective disorder to improve insight and awareness of early warning signs and identify strategies the patients can use themselves to stabilize their mood. If they are in close contact with family members, a family intervention is also recommended. In bipolar depression, a high-intensity psychological intervention is advised, cognitive behavioral therapy, interpersonal therapy, or behavioral couples therapy. Psychological therapy is not recommended in hypomania or mania when patients are generally unable to engage. Psychological therapies can harm as well as help, and therapists need to have training specifically to work with people with bipolar affective disorder. About ECT, although ECT may precipitate a manic episode in bipolar patients, it can be an effective antimanic agent, especially in severe mania and mixed states. It can also be used in a severe depressive episode within bipolar affective disorder. Course and prognosis. More than 90% of patients who have a single manic episode go on to have future episodes. The frequency of episodes varies considerably, but on average equates to 4 mood episodes in 10 years. Between 5% to 15% of patients have 4 or more mood episodes, depressive, manic, or mixed, within 1 year, which is termed rapid cycling and is associated with a poor prognosis. Completed suicide occurs around 6 times more often in people with bipolar affective disorder than in the general population. Okay, that was about bipolar affective disorder. Let's talk about dysthymia and cyclothymia. About etiology. The extent to which the etiologies of dysthymia and cyclothymia resemble those of depression and bipolar affective disorder is unclear. There are biological similarities between dysthymia and depression. For example, rapid eye movement latency is decreased in both conditions. Genetic studies link cyclothymia and bipolar affective disorder, as up to 1/3 of patients with the former have a positive family history of the latter. Epidemiology and cause. We've talked about epidemiology. Both dysthymia and cyclothymia have an insidious onset and a chronic course, often beginning in childhood or adolescence. A significant number of patients with cyclothymia will go on to suffer more severe affective disorders, most notably bipolar affective disorder. Dysthymia may coexist with depressive episodes. We call that double depression, anxiety disorders, and emotionally unstable personality disorder. We've talked about assessment, clinical features, investigations, and differential diagnosis in chapter 10 and 11. About the management. Dysthymia should be treated according to NICE guidelines on persistent subthreshold depressive symptoms, namely a low-intensity psychological therapy initially, with consideration given to high-intensity psychological intervention or medication if this is ineffective. So that's the treatment for dysthymia. There are no specific guidelines for treating cyclothymia, but again, the emphasis is on psychological intervention, supporting the individual to develop self-management strategies. If medication is felt worthwhile in cyclothymia, the options are a long-term mood stabilizer, most likely lithium, or short-term use of low doses of mood stabilizing antipsychotics like olanzapine and quetiapine during times of high stress, of course, and when mood is felt to be at least stable. Antidepressants should be used with caution in cyclothymia, owing to their occasional tendency to turn mild depressive symptoms into hypomania, of course. So that's it. Now we will go to the chapter summary. Chapter summary. Mood disorders are common and disabling disorders with onset in early adulthood. Risk factors for mood disorders are genetic vulnerability, exposure to childhood adversity, and stress. Most episodes of depression can be managed in the community, but life-threatening symptoms require hospital admission. Most episodes of mania require hospital admission. Hypomania may be manageable in the community. Treatment for depression depends on severity. Milder forms benefit from psychological intervention. More severe episodes require both psychological and pharmacological treatment. First-line pharmacological treatments for mood disorders are For depressive episodes, unipolar depression, we need selective serotonin reuptake inhibitor. Depressive episode in bipolar depression, we use olanzapine and fluoxetine or quetiapine. For manic episode, we use haloperidol or olanzapine or risperidone or quetiapine, of course. The maintenance, we use lithium for that. So that's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.